Hello, I'm Stephen Harris. I'm a senior research fellow at the University of Sheffield, and I'd like to talk to you about a work package within the project, which was a realist review, which was looking at the evidence around SARCs, particularly with their responses to mental health and substance use. So, for those of you who aren't familiar with realist approach, just a quick rundown. It works through the refinement and testing of hypotheses, which are formatted in terms of context, mechanism, outcome conjectures. Um, I'll talk a little bit about that in a moment. But it's really set up to answer a specific set of questions around what works for whom, in what circumstances, and why. A couple of key elements of the realist perspective. It values different types of evidence from all sorts of different places and different research designs. It treats ideas and meanings held by individuals as equally real to physical objects and processes, more tangible elements. And it sees these two aspects of reality as interacting with each other and mutually influencing each other. Another key element is that diversity is treated as a real phenomenon. So having lots of different outcome patterns is really, an element that the realist process investigates, rather than treating it as inconvenient and just looking for regularities and general patterns, which a lot of research can be guilty of. So constructing context mechanism outcome conjectures. A context really is anything that affects the firing of a mechanism or resulting outcomes. They can be mediating, moderating, which means that they either prevent or facilitate the mechanism of firing, or they moderate it in terms of determining the amount of effect or how it works and so on. And context can be fixed. For instance, your age group won't change very rapidly. Um, but things like, your experience tomorrow could be an element of context that could be quite changeable and influential depending on what that was. The mechanisms, so these are resources or more often reasoning, and how people respond to available resources. So how the intervention is intended to work, very much related to behavior change. Quite often, these mechanisms are latent, they're invisible until they fire in the right context, and then they can be observed. And outcomes, we expect, a variety of outcome patterns that could be intended or unintended. Just to demonstrate a very simple intervention, boiling water. What is the boiling point of water? And everyone shouts, it's 100 degrees C. And I say, it's not really that simple, unfortunately. There's a little bit more to it than that. So, if you're trying to boil water at the top of Mount Everest, the boiling point water would be 72 degrees around about, because of the lower atmospheric pressure at altitude. Even if you went up one of the local little bumps in the Yorkshire Dales, Whernside, it still has an effect of a few degrees on the boiling point of water, and that can additionally be affected by the atmospheric pressure at the time through weather, which is variable, and the purity of the water. All these different contexts can affect the outcomes, and that's a fairly simple physical process that we talk about there in terms of mechanisms. But when we start to consider social and organizational systems and interventions, it becomes a lot more complex. So people's behavior is influenced by their own characteristics, their experiences, their beliefs, their opinions, all these things that they bring to the situation, the context of the situation itself, and then other people's behavior, what they bring to the situation, and their characteristics, their experiences, beliefs, and so on. And you can see how it all becomes very complex very quickly. And there are lots of theories as well about why people behave in the ways that they do and how behaviors change. Here's just some theories of behavior change. So, for instance, the health belief model, which states that if people perceive a threat, then um, their motivation to address that threat or do anything about it is influenced by their self-efficacy. So the extent to which they feel capable of carrying out useful behaviours, and these two things interact to define behavior change. There's also things like the theory of planned behavior, which sees intention to act as the best predictor of behavior. There's the stages of change, which goes from pre-contemplation through to preparation, action, and maintenance. There's COM-B, which looks at capability, opportunity, and motivation, which then influences behavior. And all these different behaviors lead to different outcomes and different outcome patterns. So this is an example of the black box problem. So quite a lot of research has a lot of implicit assumptions between the intervention and the outcome. So you do process research around the intervention, outcomes focused study around the outcomes, and quite often a lot of what happens in between and why things are happening is left strangely just implicitly assumed. So if we start to build some theory around a program, it can start to look something like this very basic logic model, which is looking at preschool program, which leads to positive attitudes towards school and then increased school readiness. But if we look at that first and top blue arrow, you can see it's throwing up lots of questions. So why does the preschool program lead to a positive attitude towards school? What is it about the preschool program? What activities are happening there? What resources are available? How do the children's attitudes and behaviours change, and why do we expect that to happen, and so on? So it's all the detail behind the arrows that can really start to become very important. And then we come to new methods, theory-driven methods that we used in this program, where we start to look at interventions as acting in a lot of different variable contexts, and the context is important. There's a lot of different ranges of mechanisms that are in between those interventions happening in the context and the range of outcome patterns. And what we're doing is trying to get some explanatory evidence and theories together about how all those things work and how they're all related. So why do we need to know why, how, and for whom things work? So the key to this is that flexible interventions have got a much greater potential for effective spread. And when things change in complex systems, they're much more easily able to respond positively to those changes. So this calls for evaluations and research that are theory driven. Um, so we need to understand the links between actors, processes, mechanisms, context, and outcome patterns. And then we can understand the active ingredients or key principles of an intervention. And these can be adapted then to fit all circumstances rather than having a one size fits all model, expecting that to work everywhere. So here's just a quick um, diagram of the realist process. So leading from constructing initial theories, which was what this piece of work was about, the realist review. Then gathering evidence based on those theories, refining them, and then testing them, and then doing that in circular iterative fashion to build an understanding of evidence informed and mid-range theories. Here's the process logic model that we were using at the start of the program. So the blue there is the routes into service, the orange is the SARC service, and the green is the outcomes. And you can see we've got some initial outcomes, which is like feeling reassurance and feeling satisfied about the service, through to more longer term outcomes around reduced substance use and improved mental health and so on. But you see the small orange box in the middle, that's the prior organizational context. And so we started to look at all these elements and what was behind those elements and what were important characteristics of them. So just looking at that one little orange box, the prior organizational context, lots of different elements of that are important around, for instance, the size of the SARC, the culture, the values, terminology it's used, staffing skills, mix, training, and so on, clinical supervision, geographical location. Those are different elements around the organizational context that can influence outcomes. So we went about then developing some theory, so asking these questions: what's the underlying logic of the service? What are the assumptions that this is a good idea? Can we explain how the service works or doesn't work to achieve the outcomes? And what are the resources and reasonings involved? And then on to look at the important contextual factors, either individual or organizational, or combinations of individual and organizational, and the how the contextual factors then affect outcome patterns. And then we started making context mechanism outcome conjectures and if then because statements to describe all of those relationships. Main themes. So we divided into themes pre-SARC, within the SARC, things around the service organization of SARCs, and then things out and post-SARC around referrals and follow-ups. So in the pre-SARC theme, a couple of key topics there. The SARC role in raising awareness and supporting system integration of SARCs, and the SARC role in reducing barriers for vulnerable groups. Here's an example of the SARC role in raising awareness and supporting system integration. So if the SARCs raise awareness about the service and provide outreach to the community, then more survivors will access the service in a timely manner, thus providing an opportunity to improve the quality of access and improve mental health outcomes. And this is because survivors will know about the SARC, what it offers. They may be more likely to recognize that their experience constitutes a sexual assault and have more confidence that it will be treated seriously and sympathetically, and have reduced fear or uncertainty about attending. This may especially be the case for those with pre-existing mental health needs. And awareness raising may include various different activities like explaining the definition of sexual assault, and the function of the SARC for forensic and non-forensic cases, who's eligible for support, option of self-referral without police input. So you see how we started to amalgamate a lot of different evidence, a lot of different theories and assumptions that came from various literature sources and different pieces of research that have been done, and put all of these together around these themes to try and explain what was going on and why we expected certain outcome patterns from certain activities and interventions. Within the SARC, three main elements there: the mental health services and substance use provision, mental health prevention and intervention, trauma-informed care, and two elements of that, so training around trauma-informed care and trauma-informed interactions. And here's a brief example around trauma-informed care interactions and how we constructed the if then because statement. So trauma-informed interactions can improve help seeking, support steps to recovery, reduce psychological harm, lead to increased participation in the legal process, and have longer term impacts on physical and mental health. Because survivors feel respected, cared for, supported, they feel calmer, safer, and listened to, and in control and informed, and they're less likely to feel dehumanized, confused, and frightened. Reduces denial, self-blame, creates a sense of safety, and creates an environment that will be more psychologically supportive. So that's another theory that we pulled together from the evidence around the service organization. The key themes here were co-location of services, role clarity and integration, relationships with non-co-located services, and quality improvement. So again, interestingly, is another example around co-location of services. So possibly reducing the potential for negative consequences resulting from a lack of coordination and continuity of care, which could be more important for people with complex needs such as substance use problems and post-traumatic stress disorder risk factors. And post-SARC, a couple of key themes there. So the staff role in supporting service users take up follow-up services and referral to mental health services. And within that, the service user characteristics and service level issues as well. So here's another example about referral to mental health services. At a service level, This is very much looking at the available resources and mental health services. What happens when there aren't effective mental health services to refer on to? So, for instance, SARC staff addressing issues themselves or delays in referrals, um, and so on, or potentially when people are referred, there's not specialist um, services available, or there's too much variability in the approach to meet service users' needs. So from that, and then from other areas of the program, we put together a more simplified model of services. So we're going from the pre-SARC um, over to SARC activity, so identifying mental health and substance use needs, trauma-informed care, mental health problem presentation and intervention. And then we've got things around the SARC organisation down here at the bottom around role clarity, role organisation, and using data to improve services. And then the onward mental health care. So whether that's co-located or not co-located. So it just separates up everything into simple blocks that we can start to build the theory around. So in summary, some of the key issues are access problems rooted in population education, effective marketing, system integration. Key issues here are allocation of roles, responsibilities, and resources for addressing these problems. I mean, does the responsibility lie with SARCs or does it sit with other agencies? The systematic assessment and routine data capture and monitoring could be important for quality improvement activities that are locally based and context specific to ensure, and also ensure that the required skills and knowledge are available in the service. And without knowing the characteristics of service users, that is difficult to judge. The elements of trauma-informed care that are important in the SARC setting and the ways that these can improve outcomes are very clearly articulated in the literature. And the reviews extended the evidence in this field by drawing together lots of different elements into detailed hypotheses around how that works. Still some questions remained after the realist review. Some of these were regarding the ideal makeup of multidisciplinary teams and the differentiation of shared roles, responsibilities, and competencies. There wasn't anything really definitive around that. Ongoing coordination of follow-up by the SARC has benefits, but clearly relies on the availability of appropriate resources, which are often not available. So that's another area of contention. The extent to which range of services, especially follow-on services, should be provided in-house or by external organizations is a very complex issue. So this is associated with system-level integration, available services, and resources devoted to the initiating and maintaining those relationships between different organizations. So in conclusion, the realist synthesis provided a strong theoretical framework for the wider study, which was organized around the service user's pathway, right from access routes through to contact and a follow-up and referral to other services, but also considered the likelihood of repeat contact with services. The findings described how SARCs were intended to work by pulling together and synthesizing all the findings from empirical studies, which described how aspects of SARC services worked for certain groups of users, and also which recognized unintended consequences. Findings also articulated key concerns about difficulties in providing high quality services, and highlighted areas that will benefit from further investigation. And that's all for now. There's more detail in the report and upcoming publications. So thanks very much.